Good morning. It is Friday, May 22nd. I'm Bob Ravenscroft, Vice President for Advancement, here for media briefing number 48. With me today is John Woodrich, the Chief Executive Officer of Bryan Medical Center, and Dr. Catherine, or Kate Rosenberger. Dr. Rosenberger is an otolaryngologist, which is an ear, nose, and throat specialist at ENT Specialties, PC, and a member of our Bryan medical staff. She's a proud graduate of Lincoln Southeast High School, the University of Iowa, go Hawks, University of Nebraska Medical School, go Big Red, and did her residency at the University of Kansas, so Rock Chalk Jayhawk as well. She serves on a team of surgeons that are establishing protocols, pouring through research to help us move through phases of reopening and doing it safely. And I think her perspective, as we said yesterday, is really unique because of the viral load of COVID-19 transmission as it's aerosolized, and in her specialty it's obviously one of the highest exposure ones, and they're doing things safely. So real quickly with the statistics, our midnight census was 439. We have now tested 8,208 individuals at Bryan. Our positives, unfortunately, are now 1,102, and we have 394 results pending. So with that, I'll give it to John, followed by Dr. Rosenberger, then we'll open it up to questions. Thanks.
Thanks, Bob. As Bob shared with you our positives and the number of tests that we've been administering, we're still at about a 13.5% positive rate. So even with the majority of the testing you see increasing around, the percentage positive rate staying pretty consistent. We do have 28 positive COVID patients in-house, 17 of those from Lancaster County and the other 11 from outside the county. We have one individual that is pending results in-house, 10 individuals still on the ventilator, 10 in our intensive care unit, 6 in our progressive care unit, and 12 in our general care unit. And as we shared with you yesterday, next week we will be planning another mobile at Lincoln High School, and we're working with the health department on that for the cultural center. With that, I'm going to turn it over to Dr. Kate Rosenberger.
Thanks so much for having me, Bob and John. And they've asked me to talk today about my experience as an ENT and, our surgeons' experience in general during this pandemic. I've been on the surgical leadership committee, and we've been asked to come up with some guidelines to help guide reopening surgery in the safest manner possible. We started elective surgeries again on May 4th and have been gradually ramping up since then. Our guidelines have been developed by multiple surgeons from different specialties as well as administration, and it's been a good way to come together with safe guidelines to move forward. And our situation, here in Lincoln and at Bryan is different than many other places in the country. So we've been trying to keep that in perspective too, using the guidelines from the American College of Surgeons, the governor's guidelines, and putting those all together. So our phases of reopening, we've been gradually restarting these elective surgeries. Initially started with just outpatient or short stay overnight surgeries, and that was to limit the amount of inpatients that would require beds in the hospital. And that has just been gradually increasing. We've been very fortunate here at Bryan to have enough PPE to start elective surgeries and to do all sorts of elective cases. And so my understanding is that we're on track to continue to open up for fully elective surgeries by possibly June 1st, as long as everything stays stable. One thing that I wanted to talk about was my patients are asking me this every day in the office. How do I know that I'm going to be safe when I go into surgery? And what can you tell me about my surgical experience during this pandemic? I know that John and Bob have gone through multiple times probably the protocols that are in place for this pandemic screening, but just so everyone knows, I mean, there's 3 basic areas that are being done to really keep patients safe and staff. So the screening is the first step, and that is done before the patient even comes into the hospital. Screening for symptoms, questions about where they're coming from. Are they coming from hotspot areas? Have they had exposures? When they get screened again when they enter the hospital with temperature, with symptom check, and again in the preoperative area. And that can be really effective at trying to keep people out of the hospital who are potentially ill. The second step that Bryan has implemented is universal masking. And, as Dr. Johnson talked about in his talk, this is very effective at decreasing the transmission both from staff and patients, and just if there was any possibility that there could be transmission, that's much decreased with masking. Every staff member is wearing a mask, every patient's wearing a mask, so that is decreasing that risk. In surgery, we always utilize universal precautions. We're always wearing masks and gowns and gloves. It's just magnified with COVID, and so we talk about these aerosol generating procedures, what Bob mentioned, and that means that it is a surgery where potentially it is generating the aerosol of the virus that lives in the back of the nose and throat. So examples of those surgeries would be tonsillectomy or sinus surgery, bronchoscopies. All of those things can potentially aerosolize virus and put it into the air, which puts people at risk. For those procedures, we usually use an N95 mask and a face shield, or a PAPR, which is the big spacesuit looking things, the personal respirator devices. And again, we are extremely fortunate to have enough N95s and PAPRs to be doing those cases. Talking to my ENT colleagues around the country, this is not always the case. There are lots of hospitals around the country who don't have PAPRs. So we are uniquely fortunate to have access to those. So that really helps keep patients and staff safe in those high-risk procedures because we have that higher level of PPE. And the third component is preoperative testing. And preoperative testing is usually done to identify asymptomatic carriers. Because generally, if you have symptoms, we will not be doing elective surgery on you. If your COVID test comes back positive, we're not going to be doing elective surgery. So it's really to identify those asymptomatic carriers. Now, there is still a potential for a false negative result on the test, meaning that patient has COVID, but they tested negative. And if that's the case, then potentially that patient still could come into the surgical area with COVID. And that's why we are still increasing our PPE for those risky procedures. So for aerosol generating procedures, even though the patient is COVID negative on the test, it doesn't mean that we decrease our level of PPE. We still are using the N95s or the PAPRs as a safety measure to make sure that we don't transmit that to other patients or anyone in the room. Preoperative testing can be helpful for, again, those high-risk patients who are either coming from hotspot areas, if they have an exposure to another family member or something like that. It also can be helpful for immunocompromised patients or, those who are high-risk, elderly going into surgery. You may want to test those patients to know their status. One important point that we've tried to really emphasize, preoperative testing is only helpful if the patient isolates themselves from the time of testing until the time of surgery. If they're tested and then they go to the grocery store and they go out to dinner over the couple days between their testing and surgery, then they certainly could be infected, and that testing is not as helpful. So those are kind of what I tell my patients, about keeping them safe in surgery. And, I would say overall, the vast majority of patients who are hospitalized right now are not for COVID. They're for other medical reasons. I think it's really important for people to remember that there are medical issues out there that need to be treated in a time-sensitive fashion, that need to be addressed and could potentially get worse if we don't operate. And yes, a lot of these things are elective, meaning they're not urgent or emergent, but they could get worse if we don't proceed with operations. So we need to be able to do these surgeries safely and proceed in a manner that is safe for the patients and for the surgeons and the staff. I personally feel very safe, overly protected most times in surgery, and I think that the staff in the OR do too. I do just want to second Bill Johnson's plea, Dr. Johnson's plea to please continue to social distance at home and please continue to wear your masks. Lincoln's been doing, overall a really good job of keeping our numbers down. If we can continue to keep it at a low level, then the hospital can handle the volume and we can continue to do these operations, take care of patients like we would like to. And so we would just ask that you please continue those precautions if possible. Thank you.
I did see that late last night. I would think that I will want to get the physician's take on this as we move forward, but hand hygiene is going to be tremendously important, no matter if it's COVID or not, from spreading viruses and disease. And I think the key word was in your question, it does not spread easily on surfaces. It doesn't mean it doesn't spread at all on surfaces. So I do not anticipate any change in the cleanliness and the sterilization procedures that are done at Bryan.